channel. You can take all of our meetings there and see again and send to your colleagues if you think it's going to be useful for them. We'd like to invite all of you for on the 22nd, on Monday, Dr. Mary Cohen is going to continue her series and she's going to talk about imaging after surgery for single ventricles. I'm sure this is going to be very nice. Please invite your team. And on Thursday, we are going to have the third meeting of the fetal cardiology series. We are going to talk about a lot of practical approaches of the fetal cardiology. I hope all of you can join. And we are having a very nice discussion about pediatric ECG with Dr. Volkan. So in English, it's every other week. So this Tuesday, we are going to have in English. And then we are going to have one more, and then we stop for a while. Then we think we are going to restart again. In the beginning of April, on the 1st of April, we have Dr. Gil Vernovsky on his amazing CICU series. He's going to talk about the clinical research, the people who inspired me and their tips. So this is going to be very nice. It's going to be with Doctors Ethan Buchanan. It's going to be very nice. So I hope all of you can join. And to finalize our agenda, we have on the 12th of April, Dr. Norman Silverman talking about the trilogy of Fallot. The series has been very nice, so I hope all of you can join. So we are going to continue with our anatomical morphologic series with Dr. Anderson, talking about the anatomy of hearts with dominant right ventricles. Thank you very much to all of you.
Good afternoon again, ladies and gentlemen. Those of you who have been with us over the recent weeks will know that we've been talking about the way the heart develops, and we've been looking at that with regard to lesions that might be considered contentious. And you'll also know that we've made the point in recent weeks that one of the lesions that remains contentious, or rather more than one lesion, the group of lesions that remains contentious is the group that many of us still consider to represent a single ventricle or the univentricular heart. Now, you'll also know that I have problems with this because I approach it from the stance of the anatomist. And to me, as an anatomist, it makes sense to retain or to reserve the term single ventricle for those in hearts in which there is truly a solitary chamber within the ventricular mass, because I think that makes sense. And you know that one of the principles that I adopt is that we should use words that make sense to everybody with regard to the things we are looking at. I also know, however, that many of you, as clinicians, look towards the shorthand approach, and you will still want to use the term single ventricle for the arrangement in which there is only one ventricular chamber that is supporting both the pulmonary and the systemic circulations. So we are continuing these discussions today, and I want to come back to how we deal with this dichotomy, the way I look at things, and I consider myself to be a scientist, so I like the system of using words to describe what you see before you, or alternatively, the other way I think of as being the Humpty Dumpty approach. Now, many of you may well now be asking, what is the Humpty Dumpty approach? And I take you to this statement that is attributed to Humpty Dumpty. When I use a word, Humpty Dumpty said, in rather a scornful tone, it means just what I choose it to mean, neither more nor less. And I think that is the approach that many of you take when you use single ventricle to describe hearts in which obviously there are two chambers present. So where does this statement of Humpty Dumpty come from? I'm sure many of you know that it comes from the book Through the Looking Glass, which was the second book written by Lewis Carroll. His proper name was Charles Dodgson. His first book, of course, was Alice in Wonderland. And in many ways, this Humpty Dumpty approach is very much Wonderland. So I would like to take us to the scientific approach, because I've tried to explain to you that the addition of one simple word functionally restores logic to what we are talking about. So we're continuing our discussions today, and we are considering that hearts have functionally single ventricles. Now you'll remember we looked at that last week when we discussed hearts that had a dominant left ventricle. And what I told you last week is that fully to appreciate what is going along in hearts that have a dominant left ventricle, we have to do two things. We have to take account of the arrangements across the atrioventricular junctions, and then we have to put those arrangements into the context of what is happening within the ventricular mass. And last week, when we were discussing those hearts that had a dominant left ventricle, I made the point that we could distinguish between the dominant left ventricle, the second chamber present, which in the setting of the dominant left ventricle is an incomplete right ventricle, and oftentimes still we call that a rudimentary right ventricle. So we're going to do the same thing today, and we're going to look at this in the setting of a dominant right ventricle. So we're going to look at the atrioventricular connections, and again, reverting to last week, you will remember that the hearts we discussed last week all had univentricular atrioventricular connections. And almost always, hearts with univentricular atrioventricular connections, those arrangements in which the atrial chambers connect to only one chamber within the ventricular mass, almost always they are functionally univentricular. We made the point that on very rare occasions, it might be possible to septate those hearts that have double inlet left ventricle, but you know better than I that these days it is much more frequent to use the Fontan approach so as to correct those patients. But for today's discussions, we need to remember that hearts with biventricular connections on occasion can be functionally univentricular. Now, last week I could have made the point that hearts with pulmonary atresia with intact ventricular septum, in which, again, the left ventricle is dominant, the right ventricle is complete, but oftentimes grossly hypoplastic. So some of those hearts are oftentimes repaired in functionally univentricular fashion. But we did not discuss that last week. This week, however, we're going to have to discuss the situation in which some of these hearts with dominant right ventricles also have biventricular atrioventricular connections. And that is because, as part of today's discussions, we're going to be reverting to hypoplastic left heart syndrome, specifically those in which there is mitral atresia. So we're going to be looking at today hearts that have a dominant right ventricle, but then we should remember hearts making up hypoplastic left heart syndrome are probably the most frequent example of those with dominant right ventricle. As I say, we're going to be looking at those hearts. So most of the hearts that have hypoplastic left heart syndrome have biventricular atrioventricular connections. The majority, of course, have mitral stenosis rather than mitral atresia. But what we're going to see is that on occasion, even those with mitral atresia can have biventricular atrioventricular connections. But a minority do have absence of the left atrioventricular connection. And we're also going to show you that some of the patients who have double outlet right ventricle can also have absence of the left atrioventricular connection. But we also know that in the setting of a dominant right ventricle, when the left ventricle is incomplete, as was the case with dominant left ventricle, we can have double inlet, and that's what we're going to start off with. We can also, on much more rarer occasions, have absence of the right atrioventricular connection. But we're going to start our discussions today, even though this is a relatively rare lesion, by looking at double inlet right ventricle. So let me remind you what we mean by double inlet. We find double inlet when the greater parts of both atrioventricular junctions are connected to the same ventricle. We looked at that in detail last week when they were connected to the left ventricle, because the commonest form of double inlet ventricle is indeed double inlet left ventricle. Today, we're going to look at that in the setting of the dominant right ventricle. And we're going to emphasize again, those junctions can be connected to that dominant right ventricle through two atrioventricular valves, but in this setting, when the right ventricle is dominant, it's much more frequent to have double inlet through a common atrioventricular valve. As was the case when the left ventricle is dominant, those valves, be they the right valve, left valve, they can straddle and override, and this can produce spectrums of malformation. And we're going to show you those spectrums. It's also the case that when both atrioventricular valves connect to the dominant right ventricle, almost always both arterial valves arise from that dominant right ventricle, but other ventricular arterial connections must be anticipated. So we're going to start off by showing you double inlet right ventricle through two atrioventricular valves. And this is the nicest example I've ever seen of double inlet right ventricle. In fact, it's one that I encountered very early in my career when I started at the Royal Brompton Hospital a long time ago, 1974. And I started building up my own archive at the Royal Brompton. This was one of the first hearts that confronted me. You see that the big ventricle, the dominant ventricle, has very coarse trabeculations. I've labeled them as right ventricular, but you'd be justified in asking, how do I know these are right ventricular? I'll show you that in just a moment. What you can clearly see, however, is that this large ventricle with these coarse trabeculations receives the right atrioventricular valve. You can see the pectinate muscles at the back of this atrioventricular junction. And there you see the left atrioventricular valve with its smooth vestibule. So how do I know this is a right ventricle? Because when I turn the heart around, I look posterior inferiorly, I find the second ventricular chamber. And this is obviously a ventricle. It has very fine crisscrossing apical trabeculations. That tells us that it is an incomplete left ventricle. But what is more, in this instance, we can see that there is one papillary muscle left behind in this ventricle, and that is going to give us a clue to the morphogenesis. I'm going to come on to discuss the morphogenesis in a few minutes' time, but first of all, we're going to look in more detail at another example of double inlet right ventricle through two atrioventricular valves. Because as was the case last week when we were looking at dominant left ventricles, I'm dependent again on Diane Spicer, and Diane is going to show you the morphology that we find in the setting of double inlet right ventricle. We're going to start off with a lovely example of double inlet through two atrioventricular valves, and then shortly after that, she's going to show you the same thing with a common atrioventricular valve. So now Diane is going to show us our first pathological specimen.
This specimen is also as a result of cardiac transplantation. So we have the majority of the atriums and the arterial trunks previously removed. Here we see a morphologically right atrial appendage, and to the left, a morphologically left atrial appendage. You can already appreciate from the base of the heart that the right atrioventricular junction is quite a bit larger than the left. There's a remnant of the flap valve of the oval fossa here at the atrial septum. The aorta is to the right of the pulmonary trunk so that they are oriented side by side as they exit the ventricular mass. There's the right coronary orifice, and there is the left coronary artery. Looking at this heart from the ventricular aspect shows us a dominant right ventricle, so it's opened in clamshell fashion. There are the coarse apical trabeculations. The right atrioventricular valve is quite a bit larger than the left atrioventricular valve, so there is a double inlet to this dominant right ventricle. There's also a double outlet to the dominant right ventricle with both arterial trunks supported by complete muscular infundibulums. The atrioventricular valves as well are separated by a bar of muscle, and this will be important when we talk about the conduction tissue. So you can see that bar of muscle running here and all the way up between the two valves. Looking at the left atrioventricular valve, it is mostly committed to the right ventricle, but there is an imperforate portion that lies over a very tiny left ventricle. So there is that tiny left ventricular chamber. It's incomplete and rudimentary. It lacks its outlet, but its inlet is covered by a portion of the left atrioventricular valve. Looking at the disposition of the conduction axis in this heart with a double inlet right ventricle and actually a double outlet right ventricle as well, we know we had that hypoplastic rudimentary left ventricular chamber in the hip pocket of the heart, and that the portion of the left atrioventricular valve across the septum rendered the inlet imperforate. What I want to point out is that although hypoplastic, the interventricular septum, which is just in this area, deep to that imperforate portion of left atrioventricular valve, it extends to the crux of the heart, so that the atrioventricular conduction axis would be at the apex of the triangle of Koch, as it usually would be. When we look at the inside of this dominant right ventricle, once again, remember that muscle bar that separated the two atrioventricular valves. The septum would be at the crux, and the atrioventricular conduction axis would emerge in usual fashion from the apex of the triangle of Koch.
So now you've seen double inlet right ventricle through two atrioventricular valves. So we're looking again here at an example of double inlet right ventricle. There you see the right atrioventricular junction. You can recognize the pectinate muscles extending all the way to the crux. There you see the smooth left atrioventricular junction. But this time, the two atrioventricular junctions are going through a common atrioventricular valve into the big ventricle. And you can also see that that big ventricle has coarse trabeculations. This time, I've made the section in a 4-chamber cut. And now you can see how we can be certain that the big ventricle is a dominant right ventricle, because there, posterior inferiorly in the ventricular mass again on the left side, you see the incomplete left ventricle. In this particular heart, however, this left ventricle was giving rise to the aorta. There were concordant ventricular arterial connections and spiraling arterial trunks, because this is the end point of a spectrum of malformations. So now, using the example of double inlet right ventricle with common atrioventricular valve, we're going to demonstrate to you this spectrum. And we're going to show you that, as was the case with the dominant left ventricle, depending on the extent of override, we can find hearts in which there is atrioventricular septal defect with right ventricular dominance. And so now Diane is going to show you this spectrum of malformation in the setting of common atrioventricular valve that ends up with atrioventricular septal defect, dominant right ventricle. And then the question, of course, is how big must the left ventricle be before you as clinicians determine it is capable of supporting the systemic circulation. So Diane is now going to demonstrate to you this spectrum of malformation.
I'll begin this segment by letting you know that all of the hearts are as a result of cardiac transplantation, so that the majority of the atrial appendages and the atrial vestibules at the base of the heart have been removed, along with the majority of the arterial trunks. We're going to begin the spectrum with an unbalanced atrioventricular septal defect that has right ventricular dominance. We have a common atrioventricular junction with the right component of that common atrioventricular valve, the larger of the two. The left component is hypoplastic. The crest of the septum is here, and the bridging leaflets prior to sectioning were adherent to one another across the crest of the ventricular septum. So a so-called primum type of a common atrioventricular valve. This particular specimen has concordant ventriculo-arterial connections with the pulmonary trunk in its usual position, anterior and to the left of the aorta, and the aorta in an unwedged position, secondary to the atrioventricular septal defect. There is the left coronary, and the right coronary is also in its normal position, running in the right atrioventricular groove. The important point that we would like to make in this segment is that the greater part of both atrial vestibules are connected to the right ventricle, or the dominant right ventricle. So here we see the right atrial vestibule and the left atrial vestibule. They are both connected with the adjacent ventricular myocardium, so left atrium to left ventricular myocardium and right atrial to right ventricular myocardium. The dominant component of the right atrioventricular valve enters this hypertrophied dominant right ventricle with coarse apical trabeculations. Here's the interventricular septum and the hypoplastic left ventricle. The inferior bridging leaflet, as you see, is adherent across the crest of the septum with no shunting permitted at the ventricular level. The opposite half of the heart, so we're looking from the spine towards the sternum. Here's our right atrial appendage and the right component of the common atrioventricular valve, which is the dominant component. Again, the right ventricle has coarse trabeculations and is hypertrophied. The interventricular septum and the left ventricle are easily appreciated, even though the left ventricle is hypoplastic. So the superior bridging leaflet is also adherent across the crest of the septum in this heart with a common atrioventricular valve and right ventricular dominance. Putting the heart back together and tilting it just a bit, we see that hypoplastic left ventricular chamber on the posterior aspect of the ventricular mass, or as Professor Anderson sometimes says, in the hip pocket of the heart. This is the second heart in our series of those with dominant right ventricle and common atrioventricular junction. This patient had transposition of the great arteries with pulmonary atresia. The pulmonary trunk is represented only by this small remnant of the pulmonary artery. The right atrial appendage is showing us the pectinate muscles around its component of this common atrioventricular junction, and the narrow left appendage has been virtually bisected, and there's its narrow junction with the left component of the common atrioventricular junction. Looking at the four-chamber view, we see the dominant right ventricle with the dominant component of this common atrioventricular junction, where the greater part of both atrioventricular junctions are connected to the dominant right ventricle. So the parietal wall of the left atrium is connected to the parietal wall of the left ventricle, as is the musculature of the right atrium connected to the musculature of the right ventricle. The left ventricle is this hypoplastic slit-like chamber with the left component of the common atrioventricular valve shielding the opening into that left ventricle. The interventricular septum is here, and the bridging leaflet inferiorly is free-floating across that crest of the ventricular septum with only a few chordal attachments extending into the left ventricle. Looking at the opposite half of this heart with a dominant right ventricle and a common atrioventricular valve, we again see the dominant right ventricle and the slit-like left ventricle. The superior bridging leaflet also is free-floating over the crest of the ventricular septum and effectively lying over the orifice to the left ventricle, or the opening to the left ventricle. I also would like to point out that this is the leading edge of the atrial septum, so that this would be the atrial component of the atrioventricular septal defect. And in hearts with dominant right ventricle, the atrial and ventricular septums are in alignment. Yet another specimen within our spectrum where we can see there is a common atrioventricular junction. Here's our morphologically right appendage and the morphologically left appendage. This patient had a double outlet right ventricle with pulmonary atresia, and the pulmonary atresia could not be identified once the heart was explanted. If we look at the inferior aspect, the pectinate muscles can be seen around the dominant component of this common atrioventricular junction. And in this particular specimen, again, we have the greater parts of both atrioventricular junctions connected to this dominant right ventricle. Again, very coarse apical trabeculations. The interventricular septum lies here, and our slit-like left ventricle is hypoplastic. The common atrioventricular valve has the inferior bridging leaflet entirely adherent to the septum, so that effectively on the inferior aspect, the left atrioventricular orifice has been blocked. A cut has been made in that portion of the atrioventricular valve. It's been folded away from its hinge point so that you can see how it blocks the inlet to that hypoplastic left ventricle. The opposite side of this heart with a dominant right ventricle and a common atrioventricular junction. Again, we see the dominant right ventricle, the interventricular septum, and our slit-like left ventricle. Many times in hearts with dominant right ventricle and an unbalanced atrioventricular septal defect, we see a solitary papillary muscle within the hypoplastic left ventricle. A portion of this superior bridging leaflet was also adherent to the crest of the ventricular septum, so partially blocking the egress of blood between the common atrioventricular junction and the left ventricle. There was a residual ventricular septal defect beneath that superior bridging leaflet, so that this serves as the inlet to this left ventricle, since the common atrioventricular valve effectively blocks the orifice between the left atrium and the hypoplastic left ventricle.
So you also know that over the recent weeks, since we restarted our series of demonstrations at the beginning of the year, we've been looking to connect the congenital malformations to the way they develop. And it was very easy to show you the developmental background to dominant left ventricle, because you will remember that in the developing heart, the embryo starts off essentially with double inlet to the dominant left ventricle, double outlet from the developing right ventricle. It's not so easy to show you what is going on when we have a dominant right ventricle, because we never see the situation in which there is a dominant right ventricle in normal cardiac development. But we can make inferences based upon the hearts you have already seen. So what we have shown you is that during normal development, it is normal expansion of the embryonic atrioventricular canal that produces the right atrioventricular junction. And based on the spectrum of malformation that you have already seen, we know that excessive expansion can produce straddling and overriding of the mitral valve, or in the setting of a common atrioventricular junction, in unequal sharing of that common atrioventricular valve. And then we know that if there is extreme expansion, we end up with double inlet to the dominant right ventricle, either through two atrioventricular valves or through that common atrioventricular valve. Now here is a very beautiful diagram that shows you this progression that lets us understand the morphogenesis. So to your right hand, see the situation where there is no more than minimal straddling and overriding of the mitral valve. We're going to look at this again next week when we concentrate on straddling and overriding of the atrioventricular valves. So if you look at that drawing to your right hand, you see that the orifice of the mitral valve is overriding the crest of the musculoventricular septum. And then if you look in the middle and you see that we have intermediate forms, but then that is leading to straddling of the mitral valve. In this diagram, the authors of this demonstration are showing you that that can be through two atrioventricular valves, as we have seen, or through a common atrioventricular valve. And then Diane has shown you beautifully that spectrum of malformation, setting of common atrioventricular valve that ends up with double inlet right ventricle. So this, I think, is an excellent diagram to illustrate the morphogenesis of dominant right ventricle, excessive expansion of the atrioventricular junction into the developing right ventricle at the expense of the left ventricle. The amazing thing is that this comes from all the way back 1973. And this superb manuscript was written by a very good friend of mine, Manolo Caro Jimenez, and Manolo worked initially at the hospital in Madrid, La Paz, He subsequently moved to Ramón y Cajal Hospital at Madrid. He died at a tragically early age. But Manolo worked with a group of us who developed sequential segmental analysis in Europe. And I had not fully appreciated the importance of this manuscript until I looked back on it for the purpose of today's presentation. And I'm amazed at the accuracy with which Manolo, here you see exaggerated displacement of the atrioventricular canal. He knew exactly what was going on way back in 1973. And now you've seen the demonstration of the specimens that give credence to the concept he was putting forward to the development of dominant right ventricles. But we also know from what we looked at last week when we were looking at dominant left ventricles that we can have similar situations in different atrioventricular connections. So now we've covered the situation in which both atrioventricular junctions are connected to the right ventricle, either through two atrioventricular valves or through a dominant or through a common atrioventricular valve. So now we're going to move on and we're going to look at those other univentricular atrioventricular connections. And we're going to concentrate on absence of the left atrioventricular connection. I've already informed you that this is one of the variants of hypoplastic left heart syndrome, the variant in which we find mitral atresia combined with aortic atresia. But what Diane is going to show you when she demonstrates these specimens is that we have to distinguish mitral atresia in this setting from when there is an imperforate mitral valve. And of course, when there is an imperforate mitral valve in hypoplastic left heart syndrome with intact ventricular septum, there will be biventricular atrioventricular connections, showing you that hearts with biventricular atrioventricular connections can also be functionally univentricular. And then what Diane's going to show you is that the same thing can happen in the setting of double outlet from the dominant right ventricle. And these hearts also will be functionally univentricular. So she's going to show you and compare for you hearts that have absence of the right atrioventricular, the left atrioventricular connection in this setting. And then she's going to show you hearts with imperforate mitral valve, but still dominant right ventricle and double outlet. And then we also know that we can have the same situation, so-called mitral atresia, with patent aortic root, with a ventricular septal defect, but we are not going to be looking at that. So what we are going to be looking at is these situations in which there is mitral atresia with a dominant right ventricle.
Many times, by looking at the outside of the heart, you can get a feel for what you might find once you open the specimen. So here we have a morphologically right atrial appendage to the right with its blunt tip and its broad attachment to the venous component, and a morphologically left atrial appendage to the left with its narrow tubular appendage and narrow junction to the atrial component. The pulmonary trunk is quite large when compared to this very tiny ascending aorta. The right ventricle is the dominant ventricle in this heart. There are very prominent trabeculations and even a freestanding septomarginal trabeculation. This heart is cut in a 4-chamber plane, confirming that the right ventricle is indeed the dominant ventricle. There are biventricular atrioventricular connections in this case because the parietal wall of the left atrium is connected to the parietal wall of the left ventricle. So there is a potential for an atrioventricular connection in this particular case. The coronary sinus is here at the atrioventricular junction, and the mitral valve is imperforate, so that there is a diaphragm of valvular tissue along the atrioventricular junction on the left. This shows us the typical anatomy with hypoplastic left heart, where there is mitral valve and aortic valve atresia. The left ventricle is slit-like with no endocardial fibroelastosis. The interventricular septum is here, and the conduction axis would take its normal course from the apex of the triangle of Koch and run along the septum in usual fashion. This heart has the lungs attached, and looking at the anterior aspect, the pulmonary trunk is quite large when compared to this very tiny ascending aorta, which again would suggest that there is something going on the left side of the heart. You can see the aortic arch here with the brachiocephalic arteries and this very large patent arterial duct. There is a morphologically right atrial appendage to the right and a morphologically left atrial appendage to the left. Opening up the right ventricle, the trabeculations are quite coarse or thick, if you will, and this particular specimen has right hand ventricular topology, with my right hand placed on the septum, my thumb in the inlet, and my fingers in the outlet. The left side of the heart shows us an extremely small left atrium. It has been windowed. There is the flap valve at the floor of the oval fossa, and at the floor of the atrium there is a small dimple, which is where the mitral valve may have formed, so that there is agenesis of the mitral valve or atresia of the mitral valve. There is the coronary sinus running in the left atrioventricular groove, which is in this area, and there is no potential for an attachment between the parietal wall of the left atrium and the left ventricle. There is fibrofatty tissue in this atrioventricular groove, and you can see the circumflex coronary artery also running in that groove. So no potential for a connection between the left atrium and the left ventricle. The left atrial floor is muscular, and so this particular heart has two ventricles, one large and one small, but a univentricular atrioventricular connection with no potential of a connection between the left atrium and the left ventricle. The left ventricle is rudimentary and incomplete, but it shouldn't be denied ventricular status, because morphologically we can still tell that it's a left ventricle. There are fine crisscrossing apical trabeculations and a smooth septal surface towards the outlet. The outlet is absent, as there is aortic atresia. This ventricle exhibiting the typical characteristics of mitral atresia, aortic atresia in hypoplastic left heart syndrome, with a slit-like morphologically left ventricle with no endocardial fibroelastosis. In functionally univentricular hearts, where the left ventricle is the small or incomplete ventricle, they are most often on the posterior aspect of the heart, or in posterior inferior position, as is this hypoplastic left ventricle. They are often outlined by the coronary arteries, which marks the septum that has been as well pushed posteriorly. The right ventricle has been windowed in this heart. The aorta and pulmonary trunk both arise from what is the dominant right ventricle. The trabeculations within this right ventricle are quite thick or prominent, and there is a freestanding septomarginal trabeculation. There is a morphologically right atrium to the right, and a morphologically left atrium to the left. There are two ventricular septal defects, one of which is apical and behind these very thick trabeculations, and the other in subpulmonary position. The mitral valve is at the posterior roof of this defect, and it is imperforate. So there are two ventricles, one large and one small. The left atrioventricular junction is guarded by an imperforate mitral valve in this position. Looking within the floor of the left atrium, pulmonary veins are entering here, the appendage with its narrow junction there, and there is a large secundum type of atrial septal defect. The mitral valve has a depressed appearance, and it is imperforate, so that there is a diaphragm of valvar tissue preventing blood from going from the left atrium to the left ventricle. The parietal wall of the left atrium remains connected to the parietal wall of the left ventricle, so that there is a potential for a connection at the left atrioventricular junction. So this specimen has biventricular atrioventricular connections, or a potential for a connection at the atrioventricular junction. The mitral valve lies immediately adjacent to the ventricular septal defect. That's closer to the base of the heart. And here is the apical muscular ventricular septal defect that was hiding behind the trabeculations within the right ventricle. Looking at the right side of the ventricular septal defect towards the base tells us that it is an outlet ventricular septal defect. It lies within the Y of the septal band, or between the caudal and cephalic limbs. And the caudal limb is maintaining its attachment to the inner heart curvature, or the ventriculoinfundibular fold. The conduction axis would emerge in this area so that the membranous septum remains intact in this particular specimen, and it would run along the edge of this muscle bar. There's the medial papillary muscle, and then branch in its usual fashion. This specimen has the lungs attached, and you'll note that the left lung is quite a bit smaller than the right, as the patient had a diaphragmatic hernia. Here you can see the superior caval vein entering the roof of the morphologically right atrium on the right side, and the aorta is quite large and anterior. The aortic arch extends to the right, and there's a bit of a strange branching pattern. The left carotid comes off the aorta quite low with respect to the arch. The right carotid, the right subclavian, and there was distal origin of the left subclavian. Tilting the specimen shows us that the pulmonary trunk is quite a bit smaller than the aorta, and it lies in almost posterior position relative to the aorta. Looking within the right atrium, there was premature closure of the oval foramen with aneurysmal dilation towards the left side, but there is no possibility of getting a probe through there. The coronary sinus, as you'll note, is quite large, secondary to a persistent left superior caval vein. The tricuspid valve is a bit dysplastic with thickened rolled edges. And this right ventricle is the dominant ventricle. It is a morphologically right ventricle with right hand topology. My right palm can be placed on the septal surface with my thumb in the inlet and fingers in the outlet. There is a small ventricular septal defect in the subaortic position. And looking at how the arterial trunks exit this dominant right ventricle shows us that the outlet septum between the two valves is fibrous, so that the aortic valve and the pulmonary valve are virtually in fibrous continuity with one another at the base of the right ventricle. The right ventricle, as I said, is the dominant ventricle, and if we look on the posterior aspect of the specimen, we see a very hypoplastic left ventricle. The inlet to this left ventricle is absent, as the floor of the left atrium is muscular. This left atrium is so small that I was not even able to open it. The persistent left superior caval vein runs along the posterior wall of the left atrium. The appendage is this very tiny pedicle just there. And within this left atrioventricular groove, there is the circumflex coronary artery. So that there is just a fibrofatty plane between the muscular floor of this extremely tiny left atrium and the musculature of the left ventricle. The ventricular septal defect that we saw from the right is close to the base of the heart and extremely tiny. So this case has a small left ventricle and a dominant right ventricle. This specimen is a functionally univentricular heart with a small left ventricle or incomplete ventricle lying on the posterior inferior aspect of the heart relative to the dominant right ventricle. It still maintains ventricular status, as it is a recognizable ventricle with fine apical trabeculations and a smooth septal surface on the way out. There is a univentricular atrioventricular connection in this case, secondary to the muscular floor between the left atrium and the left ventricle. So no potential for an atrioventricular connection in this case.
If you remember what we looked at last week with dominant left ventricle, and you will see that we are trying to tell a similar story this week so that you have a means of analyzing what you may well think of as complex congenital cardiac malformations. One of the other important features last week was ventricular topology. And so you'll not be surprised to learn that we have to take this into account also when we are thinking about these lesions that have dominant right ventricle. Because thus far, all the hearts that you've seen have had usual atrial arrangement, and they've had right-handed ventricular topology. But it is the case that rarely hearts with dominant right ventricle can be found with left-handed ventricular topology. We don't have any specimens to show you, so I'm going to show you some still images, because this time we can find another spectrum of malformation. In fact, the spectrum is the mirror image of what you saw in Manolo Caro Jimenez's diagram. This time, in left-handed topology, it is the mitral valve on the right side of the heart that shows the spectrum between double inlet, dominant right ventricle, and discordant atrioventricular connections, in other words, congenitally corrected transposition. So here is the better end of that spectrum that we see with left-handed ventricular topology. In fact, you will recognize that I'm showing you the right side of a heart that has congenitally corrected transposition. So that is the vestibule of the morphologically right atrium. You can see those pectinate muscles. You'll recognize the smooth septal surface of the morphologically left ventricle. And since the valves go with the ventricles, and since we have here the left ventricle, it's somewhat hypoplastic, but as yet it is not incomplete. The larger part of this valve is entering the morphologically left ventricle, and we know that it is the morphologically mitral valve. But what you see is that a small part, the mitral valve, is passing through this outlet ventricular septal defect into the left-sided morphologically right ventricle. And again, there is a spectrum of malformation. At this time, the atrioventricular junction is expanding leftwards. And here now is the end of that spectrum of malformation. This time, I've sectioned the heart in four-chamber fashion. You're looking at it from the front. So you see the right side of the heart to your left hand, the left side of the heart to your right hand. And so that is the big ventricle. And again, you can see it has coarse apical trabeculations. It has double inlet. There are both of the atrioventricular valves entering the big ventricle. How do we know for sure it is a dominant right ventricle? Because there, tucked in the inferior margin of the ventricular mass, but this time on the left side, on the right side, rather than left side, we have that incomplete left ventricle. And if you look carefully, you can see that there is still a tiny bit of tension apparatus of that right-sided mitral valve that has retained its connection with the incomplete left ventricle. So this is the mirror image of the spectrum that Carol Jimenez described in terms of exaggerated displacement of the atrioventricular canal, this time in the setting of left-handed ventricular topology. There is one additional lesion that we now have to take account when we're thinking of a dominant right ventricle. And this is the uniatrial and biventricular connection, because the right ventricle can be dominant in this setting. And I'm going to show you an example when it is the right atrioventricular connection that is absent and the left atrioventricular valve that is straddling. So here you will immediately recognize that you're looking at the floor of the morphologically right atrium. And there is another point to be made here, because if I simply showed you this picture, you would be correct in thinking it might represent tricuspid atresia. In fact, as I'm going to show you, it is not tricuspid atresia, it is mitral atresia. But it is the floor of the morphologically right atrium. And there, as you saw last week when we were looking at classical tricuspid atresia, you know that in the floor of the right atrium, there is a dimple. And the dimple does not point towards the incomplete ventricle, it points into the dominant ventricle. So the question, what is the nature of the dominant ventricle? To where does that left atrioventricular junction connect? So here is the other side of that heart. So you'll recognize there is the smooth septal surface of the morphologically left atrium. In fact, you can see the horns of the flap valve of the oval fossa there on the septal surface. And so you're looking at the left atrioventricular junction. And you can now see that the left atrioventricular junction in its larger part is connected to a coarsely trabeculated, dominant left-sided ventricle, which is the morphologically right ventricle. Because the left atrioventricular valve is straddling the ventricular septum. There you see part of it extending across the ventricular septum, again into an incomplete morphologically left ventricle in the inferior margin of the ventricular mass, but this time on the right side rather than the left side, because again, we have left-handed ventricular topology. So here we have a very nice example of the uniatrial connection. This is the left atrioventricular junction. As I've shown you, the right atrium has no communication with the ventricular mass. The left atrioventricular junction, however, is straddling and overriding a ventricular mass that is showing this left-handed ventricular topology. So it is the morphologically tricuspid valve that is straddling, and that is why we know, had the right-sided atrioventricular junction developed in this setting of left-handed ventricular topology, it would have been guarded by a mitral valve. And that's why I told you that floor of the right atrium in this instance could not properly be described as being showing tricuspid atresia. In reality, it was showing mitral atresia, to be precise, absence of the right atrioventricular connection. So what we have been showing you today is that, as last week we saw that the left ventricle could be dominant in the setting of an incomplete right ventricle, today you've seen those situations in which the right ventricle can be dominant, giving us the rare variant of the functionally univentricular heart. I hope you will have recognized now that they are not single ventricles. All the hearts we have shown you today have had dominant right ventricle with hypoplastic left ventricle, and in most instances, those hypoplastic left ventricles have also been incomplete because they lack either the entirety or the larger part of their inlet component. As with the dominant left ventricle, it is the ventricular septal defect, the interventricular communication, when present, that is functioning as the inlet of the incomplete ventricle. But what I hope we have shown you is that if you take a logical approach to diagnosis, if you know the possibilities, you know that can be variation in atrioventricular connections. Providing you know what those variations are, you can anticipate what you might encounter. Combine that with the variations you might find in the ventricular arterial connections, and you can make an accurate diagnosis of all the hearts we've shown you today with dominant right ventricle. And that is then going to lead us on to next week's presentation. Because throughout today's demonstration, we've been talking about spectrums. And those spectrums represent straddling and overriding of the atrioventricular valves. So that is what we're going to concentrate upon next week. We're going to show you those spectrums of straddle and override of the atrioventricular valves in right-handed topology, left-handed topology, and we're going to emphasize again what can happen when we have the uniatrial but biventricular connection.
Thank you very much for this presentation. It was very illustrative. Thank you, Diane. Thank you, Dr. Anderson. And we are going to start with our discussion. Guys, please type your questions on the Q&A chat box. We have an amazing panel today, so they can discuss a lot and answer all of your questions. And as usual, I'd like to invite Dr. Silverman to give his thoughts about what was said.
Well, thank you very much, Grace, and Diane and Bob, what a fabulous collection you put together for us today. The thing that struck me was if I put myself in Jeff Jacobs's shoes and wanting to classify these, what would the primary diagnosis be? It wouldn't be functionally single ventricle, surely. It would be something like a right dominant or left dominant AV septal defect in many of the instances you have shown. I'm certainly looking at this as a functionally single ventricle, but the primary diagnosis of many of these hearts would be AV septal defect rather. Would you agree?
I would agree in the setting of the common atrioventricular junction. And I think But that's why we started off by showing you that you could have hearts with dominant right ventricle with 2 AV valves. So there's no way in the ones with 2 AV valves that you'd be calling those atrioventricular septal defect. And there the diagnosis would be double inlet right ventricle.
Yeah.
What we tried to show you is that, in fact, double inlet right ventricle, and I referred back to that beautiful paper published by Quero Jimenez as long ago as 1973, and he showed in that the spectrum from straddling mitral valve with concordant atrioventricular connections to double inlet right ventricle. And the point we were trying to make is that if you look at the cases with common atrioventricular valve, then the hearts that Diane showed you, in one of them in particular, the common atrioventricular valve was exclusively connected into the big right ventricle. So in that instance, I hope you would have called that double inlet right ventricle through a common atrioventricular valve. But as you say, the point we were trying to make is that when you look at that spectrum, the other end of the spectrum is indeed atrioventricular septal defect with dominant right ventricle. So I hope the point we were making is for you as clinicians, you have to determine within that spectrum when is that left ventricle of sufficient dimensions that it will support systemic circulation on its own. And you know, and Alan will know, you all know better than I, that that remains one of the big conundrums for you in the clinical setting. And Merrill has spent a lot of time trying to work out algorithms that Alan is working with the people in Southampton. They also have addressed this problem. And maybe we can ask Alan to speak on this, because as yet, I don't think that the situation has been resolved.
Indeed, I think that these are very challenging clinically, these hearts, because, for example, you can have a atrioventricular septal defect with no ventricular component and a large atrial component, for example, and with a left ventricle which reaches the apex. With one heart like this, we tried to reduce the size of the atrial component to see if we could encourage more growth in the left ventricle, and they maybe didn't make it at all. We thought that the left ventricle could support the circulation. We were misled because they were shunting the atrial septum, and they're very challenging to treat. And I think sometimes that atrioventricular septal defects in this setting are worse almost than hypoplastic left heart syndrome. Traditional hypoplastic left heart syndrome may seem to be almost worse. What do you think, Norman?
I've had exactly the same experience as you have. I mean, you think you're dealing almost with a ostium primum ASD with very little in the way of what we find. Unfortunately, Merrill is not here because she says that the ones with a large ventricular component are worse. But my experience in terms of mortality has been exactly what you have described, is that you think that it's going to be a cakewalk, and the infant says that the left AV valve is not capable of receiving the blood. So when you septate the heart, what you do is you get a terrible pulmonary hypertensive situation. And I've seen the patch actually rupture. And at the time that the patch ruptures, the patient suddenly improves because the pulmonary hypertension is dissipated. So I think, as a clinician, one has seen that problem, and it's certainly a very important point that you make.
Well, coming to that, it was interesting that one of the hearts that Diane showed you, in fact, the heart she showed you with the AV dominant, what she called the AV dominant atrioventricular septal defect, was a transplant specimen, which tells you the patient didn't do terribly well. And she demonstrated that heart. I should tell you also that Diane is a lucky girl at the moment because she's off with her husband. They're going to play golf. You'll notice that the last thing we saw her, she was in her car. They're going to play at a wonderful golf course in Tampa that is called Innisbrook. I've played there with Scott and Diane previously, and it's a wonderful golf course. So we should wish them all the very best in the remainder of the day today. Yes. So she was with us early in the morning. We have to be grateful to her for that. There she is. She's in the car. You see, she's on the way. So I hope the sun is shining and the weather is good.
Yes, I hope so. And Bob, I hope you get out to Roehampton pretty soon.
I'm hoping that too. But But she showed you that case with the ostium primum defect, and she showed you how in that heart the two bridging leaflets were joined to each other. They were both attached to the crest of the septum, and as you say, that is just as big a problem as when you have a common when the valve itself is common.
I'd like to just make one other point, Bob, and it's something that I haven't previously noticed. Diane showed us a beautiful example of an isolated papillary muscle within the left ventricle.
Yeah.
And I have actually, as I think back on my career, I have never actually looked at to see whether we can see the support structure of the papillary muscle. Is that a rare occurrence, or does it occur commonly?
Well, yeah, it depends on how you judge frequency. I've seen very few examples of hearts that have complete double inlet right ventricle, either through a common AV valve or through two AV valves. The first heart I showed you, that beautiful heart, which was the first that I encountered in 1974 when I started the Brompton, you'll have noticed that in that heart, there was a papillary muscle left behind within the incomplete left ventricle. So I don't know the answer to your question. I think it all depends. A lot depends on the environment on which you're looking for these things. I mean, it's something that, as we're learning all the time, and as we have these webinars, the question comes up, and as the experience broadens, we can all ask the question. When we see those small left ventricles, do they have a papillary muscle left within? It's certainly that it is possible that they do. What was interesting in the cases that Diane showed you that have absence of the left AV connection with the dominant right ventricle, those did not have any papillary muscle. There you just saw the smooth septal surface of the left ventricle. They were slit-like. She made the point again and again, they're in the hip pocket of the ventricular mass. In most instances, they're in the left hip pocket. But then I showed you, if you have left-handed ventricular topology, you can have the same thing where the incomplete left ventricle is in the right-handed hip pocket.
Sure. I was one last point, I think a teaching point for the ultrasound people that are here, is that it gets very complex when the heart is in the right chest, and it's often confusing. So if you can assert that there is in fact a mirror image atrial arrangement, it's easy to flip the switch so that the heart then appears to be left-sided, where we conventionally understand what's happening, work out what's going on, and then put it back on the right side and demonstrate it on the right side. So mirror imaging has certainly got an advantage echocardiographically, because you can put things in a more conventional way that you see them, and it becomes quite obvious what you're dealing with. I hope I'm making that point clearly enough, Bob.
But you would only do that in the setting of mirror image atrial arrangement.
Exactly.
You wouldn't do it for congenitally corrected transposition.
Correct.
It might be a good thing to do a retrospective study looking at these unbalanced atrioventricular septal defects and the status of the papillary muscles. We have several people that are probably on this call that can pull together our collections and get a fairly large cohort to look at that.
I actually classify all of my right dominant AV septal defects by classification, so I could actually run that through quite quickly.
It would be interesting if you could do that to see what you find in the clinical setting as well as in the morphologic setting, and the archive setting.
Yes. Sounds like a good project.
Indeed. All we need is time.
That's correct. And we have so much of that, Bob.
We are hard pressed these days keeping up with the Congenital Heart Academy. I've been giving Diane a hard time over the past week in preparing for next week's straddling valves. So it keeps us on our toes.
Yeah, it certainly does.
But I have to say,
it's not just one Congenital Heart Academy. There's Merrill on Monday. There's a fetal on Thursday. You again on Friday. I mean, they're sort of sitting around here. living Congenital Heart Academy, which is
This
a
is
great
true,
pleasure.
but we have our time cut out to keep the Friday seminars going. But I have to say that I thought the images and the videos that Diane presented today were quite spectacular. And when you realize how small that incomplete left ventricle is in the setting of mitral atresia, the way she was able to show that to everybody today, I think was quite spectacular.
Yes, absolutely. Everything was spectacular today. You maybe want to answer some of the questions?
Well,
Yeah.
Grace is in charge there.
So we have some questions, and very interesting, and thank you guys for participating and making your questions. So Dr. Paulo Zelinski from Brazil, a friend of mine, he's
Paulo
asking.
always has some good questions.
Yes, sure. And would be fair to say that in AVSD with dominant RV, even though there is a common AV valve, there is alignment between atrial and ventricular septum. And in univentricular AV connections with double inlet right ventricle, there's a malalignment between atrial and ventricle septums. And that this atrial and ventricular septum alignment would be the point to make the differential diagnosis. From an echocardiographic point of view, it looks the easiest way to do it.
I agree with that, and certainly in the setting when I look at I compare dominant left ventricle versus dominant right ventricle, and Diane also made that point in one of the specimens. The atrial septum retains its alignment with the ventricular septum when the right ventricle is dominant, whereas when the left ventricle is dominant, there is that malalignment between the base of the atrial septum at the crux and the muscular ventricular septum that moves away from the crux. And as in common atrioventricular valve, what you showed you with straddling tricuspid valve, you then get an anomalous location of the conduction system. So I think it's, to me as a morphologist, that makes sense. Alan and Norman might also be able to comment on that.
Yep, makes perfect sense. Yep.
Norman?
Well, I was busy, Bob, searching my computer to see. I have 69 cases of right dominant AV septal defects that I can go through and look and see which ones have papillary muscles and which ones don't. So I'm ready to start searching these for you guys.
And you could also, in that instance, also look at the septal alignment.
Correct.
So it would be well worth, if you will, we'll hold you to that. Grace, we shall ask Norman to do a Congenital Heart Academy webinar on right ventricular dominant AV septal defect.
Yes, right.
Showing the fineness of your collection, yes.
And I'm sure, as he usually does, he'll steal all Diane's pictures because he's very good at stealing Diane's pictures.
They're already on my computer because I'm preparing the session for our functionally univentricular connection for our publication.
Right.
It'll be coming your way.
He uses her images. He doesn't steal the images, Dr. Anderson. He uses them.
Don't you believe it? He steals them as well. We can't trust him.
That's not fair, Bob.
Everybody steals stuff. Everybody does.
Thank you very much for your support, Grace.
Well, we have more questions. So Mateo Rios is asking, can you postulate probabilistically, I think that is the incidence that he means, of left or right functionally univentricular heart in heterotaxis syndromes?
Again, this depends on where you're coming from. Rodney is not with us today. He was with us 2 weeks ago. I think he's celebrating his wife's birthday today. But Rodney, a long time ago, did an autopsy study on double inlet ventricles. And we published that in the 1980s. And when you look at autopsy specimens, by far the commonest condition is dominant left ventricle, double inlet left ventricle. So I think nowadays, when you take the whole sequence of functionally univentricular hearts, it's overwhelmed by hypoplastic left heart syndrome. Because nowadays that is the commonest form of functionally univentricular heart. So I think where you talk about frequency, it depends entirely where you're going to draw the line, how you're going to create your groups. I mean, Norman, what would you think from the clinical setting?
Bob, sorry, I was, can you just repeat the question for me?
I think the question was, if we're talking about functional univentricular hearts, are we more frequently encountering dominant left or dominant right ventricles?
I think dominant left really overwhelms the situation. I think dominant right ventricles, again, and then my problem with dominant is that most of those, I've just looked at one of my patients who's got a papillary muscle within the left ventricle.
No, we're talking here, I mean, hypoplastic left heart syndrome, I would be including as having a dominant right ventricle. So
Yes.
if you look at the patients nowadays who are going forward for the Fontan circulation,
Well, that's right.
probably 3/4 of Alan.
Vast majority don't.
Hypoplastic left heart syndrome is the common disease.
I mean, the interesting thing is that through the 1980s, we were all very interested in double inlet left ventricle. But Alan, how many cases these days do you see of double inlet left ventricle?
Very, very few. Very few.
I'll just quickly go to my computer and tell you how many I have on my computer. And but this is a career, so I think that gives you some idea.
You're backed up. You back your stuff up.
Pardon?
Is it all backed up?
It's all backed up. Yes, thank you. That's everybody always asks that question. I have 5 different backups of it. So I'll just look at the number of cases. It'll take me a second to get that. So if there's another question, I'll get you an answer.
Okay, sorry, Dr. Diane, you can go ahead.
I just want to let you know I'm going to sign off now. Thanks.
Okay, thank you very
I
much.
hope you have a good game at Innisbrook and lovely golf course.
Thanks.
Thank you.
Enjoy your Friday.
I've
So,
got 100 cases.
How many?
100 odd cases of double inlet ventricle in my career. And if you want to know how many hyperplasts I've seen, I can give you that number now too. Well, rather than my career, I can talk about 269. So it's at least 2.5 times more common. And I don't know that I've actually saved every hypoplastic left heart syndrome that I've seen.
So if you look at your cases of double inlet, how many are double inlet left? How many are double inlet right? And how many are solitary and indeterminate?
The solitary indeterminate, 1 or 2, Bob.
Right.
Double inlet right, I think maybe 20 or 30 patients, and the rest are double inlet lefts.
And that would be in keeping with what Rodney found when we looked at the autopsy series. So
yeah.
So
Alan,
you guys,
Alan, how many have you seen?
I've never seen. I've only seen pictures of indeterminate ventricles. I've never seen one.
What about double inlet right with 2 AV valves?
I think I saw some in Toronto.
But not in Southampton.
No, or Brompton, no.
Those Canadians are strange people, you know. Some of my best friends. Anyway, so I can give you those statistics almost immediately by going through my database. But I think that, yes, dominant left ventricles are the common in double inlet.
Yeah.
do you think, guys, this changed over time because of genetics and the environment, or we are making more the diagnosis and these patients are living more?
The latter, almost certainly, because when we started off, I mean, when Norman and I started off, hypoplastic left heart syndrome always ended up in the archive. Nowadays, what?
That's
Alan,
a euphemism.
9/10 or 9/10 of hypoplasts survive these days, do they not?
They do. Well, they
depends.
survive. It depends on how you count them, because many of them are surviving the first stage. But I think the long-term survival is only between 60 and 70% when you go out. It depends on how far you go out with the hypoplasts as to how many of them are surviving.
But by the same token, go on, Alan.
There's a very good paper from Kate Brown at Great Ormond Street looking at all the patients in the UK over the last 15 years, 10 years anyway, and with intention to treat hypoplastic left heart. And we all believed that the survival was better than it actually was. And survival to the age of 5, transplant-free survival was 50%, which is disappointing. We thought it was better than that.
I can quote Bill Winofsky, who in one of these seminars used the 60 to 70% rule. So If you go back and look at our seminars here and hear what the Master Gil Winofsky has to say about it, you'll find that in his feeling about hyperplastic left heart is that is what is important, is to look at the long-term prognosis. And the question of long-term, of course, becomes one of definition. You take them to 10 years, to 20 years, to 30 years, and so on and so forth.
But it is intriguing that, Andrew, that Alan said transplant-free, because everybody must have noticed that today the majority of the hearts that Diane was showing you were transplant who had been explants. She's now, all the material she's showing you now is from All Children's Hospital in St. Petersburg, the Johns Hopkins Center there now, and they are one of the centers for transplantation. And it's interesting, so many of the hearts that she showed you are explants, and that's the way we're seeing them these days.
And that's true about transplants, the hyperplast, because I mean, many people in counseling these patients on a fetal basis are talking about a 4-stage operation: the Norwood, the Glenn, the Fontan, and the transplant.
Yeah.
And they're not stopping at transplanting of the heart. They're also considering that the liver takes a hit, and of course, as Jack Rychik and many of the other colleagues have done it now, there's a great push to look at the liver, which actually has to look at pulmonary venous pressure, which it doesn't like to do, and develops a cirrhosis of the liver and fibrous tissue there. So the story is not ending in terms of hyperplastic left heart syndrome.
Counselling is so important. It makes a huge difference to what happens. Huge difference in the UK.
So on that basis, Alan, are parents still opting all the time to go for it, or is there a return towards termination?
It very much depends on regions. I think there must be a cultural input into that, religious input into it. But I mean, 50 to 60% probably are continuing altogether.
Despite what they know is before them.
It varies a lot. And also there's a trend now towards comfort care instead of termination of pregnancy, because it's felt to be better psychologically in the longer term.
Yeah.
But, you know.
Yeah, I think it's a very complicated issue. And, you know, I think that it's also depending on culture and environment. There are some centers where termination or even comfort care is not considered. And I think that in different socioeconomic groups, there are different variations in how you see that. So, for example, even in my area, which is our contiguous state is Arizona. In Arizona, almost no terminations occur. Okay, it's a different population. In California, still 20 to 30% are opting for termination or comfort care.
Grace, what's the situation in Qatar?
So here, in theory, we don't have termination of the pregnancy. We can, even comfort care is a little bit more difficult for cultural reasons, but we have very good experience with the parents, and sometimes we advise not to move forward, but not with the pregnancy. All of them, in the end, they are born. Sometimes we are able to do comfort care. Another thing is that we don't have heart transplant in Qatar, again, for cultural reasons. The determination of brain death is a little bit difficult. It's moving forward a lot. It's improving a lot. So now they accept better the diagnosis of brain death. So we hope that soon we are going to be able to start cadaveric transplant. Nowadays, we only have inter-live people transplant. So with donation of the parents, or so we have kidney, we have cornea, but we don't have, for example, we have a liver, but we don't have heart, we don't have lungs because of that. And we hope that this is going to move forward. So here, usually these patients, they are born, and then on the ICU, we talk to the family. Well, it started on the fetal consultation. The fetal cardiologist talked to them about the prognosis, but the huge majority don't terminate. The huge majority continues with the pregnancy.
Is Sasha still with us?
No, Sasha, I think he left.
A good friend of ours, the late Bob Freedom. who wrote a little editorial about a paper I once wrote on pulmonary atresia with intact septum. And his comment at the end was, how could something that is this small cause so much grief? And I think that's what we're looking at in this group of patients as well, Bob.
Well, Alan McGee will remember that when Freedom wrote that paper, I don't know whether Alan was at the Brompton at that time, but everybody thought he was talking about Andrew Reddington.
That's true.
Oh, Bob, you can be actually quite vicious. Because you have got me stealing your slides, Bob. I haven't stolen them, I'm just lending them. Borrowing them, I mean.
Guys, let's move forward with somewhat questions because we are really late on our time. We have an interesting question from Miguel. He is asking the differences, if there are any, on the cleft of the AV valve, if there is a single ventricle physiology or if a biventricular AVSD.
Absolutely no difference whatsoever. It is still the zone of apposition between the bridging leaflets. The only difference when it's all going into the dominant right ventricle is that the mural leaflet is very much smaller. But what you would call the quotes cleft would still be the zone of apposition between the bridging leaflets.
And Demek is asking something that is interesting because we see in the clinical practice how easy or how difficult it is to identify this physiology during the fetal life or in the first echo after birth.
Norman, that's for you.
Just repeat that again. I was looking at the questions. What was the story?
The last one, he is asking how easy or how difficult it is to identify during the fetal life or in the immediate first post-birth echocardiography. Sometimes we still have doubt. Sometimes we do a hybrid to aid the patient to grow up a little bit so we can decide if it's a single ventricle physiology or if it's a biventricular.
Well, you
So
know,
how do you
it's a very complicated question. The first thing is I would never, although I think you can see dominance in a fetal echocardiogram, I don't think there's any need to make a decision about what the treatment is, because with the development of the fetus, there is obviously dynamic changes that occur. When the left ventricle doesn't fill, it gets smaller and smaller. And so this has got to be deferred to birth to make the decision. We have been responsible for a number of papers where the ventricles have been thought to be rather on a one ventricle type of pathway, and we have been able to achieve successful two ventricle repairs. And so I think that this is largely a decision that has to be made by the surgeon when he looks at the valves at the time of doing the surgery, whether that can be. I would say that, again, if it's like the disasters that Dr. McGee and I were talking about early, that should try to be avoided. And perhaps a single ventricle repair in that situation might be more satisfactory. But I think that the other point about this is that one of the things that we look at in an autopsy specimen is that there is no dynamism, and the AV junction is a dynamic structure, and the ventricles are not pieces of plastic. They can expand, and so you really have to be very careful about making a decision of whether this is a one or a two ventricle repair. And we have done that. We both with left and right heart hyperplasia, in fact. So I think that the answer is it's very difficult to make this decision. And it is a decision that has got to be made finally and ultimately by the surgeon. And I don't know whether Sasha would, if he's still here, whether he would say anything about it. But my feeling is that I'm happy to be in the operating room with the surgeon and tell him what I think, but I'm much happier to have the surgeon tell me that he feels, yes, he could do a two ventricle repair on this patient, or no, he feels that he couldn't. And I would leave that decision with him with most respectfully.
But what about Norman, if you're talking about AV septal defects, and Alan can also comment on this, when Joseph Vetricatu was still in Southampton before he moved to Grand Rapids, he started doing very intricate measurements using all three planes. And that's what Merrill has tried to do also. And so measuring the angulation of the AV junction, how much of the AV junction was pointing to the right or the left ventricle. Do you think those algorithms are of value now?
You know, yes, I tell you, this is the thing about algorithms, is that on the extremes, where you don't need it, it's very easy to make the decision. But when you get into the middle, that's where problems occur. And I don't know how much measurement means in that circumstance. And I say this particularly with the thing about whether one does a 1 or a 2 ventricle repair in a aortic stenosis, whether you can go down a Norwood pathway or whether you can fix the valve. And we had several patients where using criteria which were intricate with a huge algorithm based on multiple issues. We had several patients that would have been predicted to have been 1 ventricle repairs that landed up being 2 ventricle repairs. So I think these things are fine, but it always worries me when you apply a mathematical equation to make a decision about a patient's life.
Alan, are you still doing measurements? So Tara was still doing measurements, wasn't she?
I don't think we are really, no, I don't think so. But my only comment would be that guidelines, when a guidelines ends, where medicine starts. When guidelines end, medicine starts.
So what you're saying is you would eyeball it.
I think that we've tried very hard over the years to establish algorithms for single ventricles, and none of them are perfect. None of them are.
Of course, Bob, what you have to think of surgically, and I think the surgeons shy away from this, is you go down a route and you say, oh, it's a 2 ventricle repair, and you do the repair and the patient doesn't come off bypass. Then you have to go back and do a 1 ventricle repair, and that becomes a much increased morbidity and mortality. So that's really this is the reality of surgical judgment, unfortunately.
And in that respect, I think the 1 ventricle, if you opt for a 1 ventricle in the first place, you're much more likely to come out with success, are you not?
Yeah. Dr. Pedro Del Nido has said a good 1 ventricle repair is much better than a bad 2 ventricle repair.
Yeah.
Sure.
Just one final question, guys, if it's okay for you. Miguel again is asking about the AV valve dysplasia in this population.
What about it?
He's asking about. So he's saying that in single ventricles with single AV connections, can we find accessory tissues or other types of mitral and tricuspid valve dysplasia?
Anything is possible. I mean,
not only possible, but happens. And I think that one of the tragedies of a beautiful double-inlet ventricle is you have a beautiful double-inlet ventricle and you think you've got like a car, you have a spare tire that God forbid one of the valves should go, you've got the other one. And many times there are lots of problems with one of the AV valves.
Sure. It was an amazing session, guys. Thank you very much.
I'm sure. Is Sasha still with us, or is he gone?
No, he left. He left.
Need to work.
Yeah, it's still Friday. Yeah.
Well, thank you very much for a wonderful session, everybody. Alan, it's great listening to your commentary.
Well, thank you. It's always good to chat about these things.
Are you going to be with us next week?
I'll try to. I'll do my best.
Okay.
Let's make sure what time this meeting is going to be held next week. I panicked like crazy because I couldn't get in because of my time zone problem.
I don't think the European time changes, does it, Alan? It's only us that changes, isn't it?
Yes. For now, sometimes it changes, but not. Okay, so see you guys. We have a lot of things going on. We have the Congenital Cardiology Anesthesiology Society. They have a 2-day conference this weekend. So please join if you are interested in intensive care and anesthesia. I'm sure it's going to be very useful for everybody. And Monday, see you guys with Mary Cohen. Bye-bye.
Thank you. Would you send me an invite, will you please?
Yes, sure.
Great.
I'll send you by email
Thank you.
now.
Bye.
Bye-bye, guys.
Thank
Bye.
you very much, Bob.
Cheers.
Cheers, Bob.
Hope you play some golf soon, Bob.
So do I. We're still locked down at the moment.
Make you feel better.
Cheers.
Okay.